All right, it's a couple minutes past the hour, and we're filling up pretty quickly. So I think it's probably about time to get started. I really appreciate everyone coming out tonight to this our 2021 LGBT Health Forum. Those of you who have been with us a while, and I see a lot of you who have on this call, I'm glad to see all of you coming back. Traditionally, like so many things, we used to be an in-person event until certainly last summer. And this summer as well, we were forced into an online format before everyone understood what was going to be happening with COVID. But we really anticipate and look forward to coming back in person, in the flesh, on campus at GW, hopefully next summer. But this is a tradition that started with the beginning of our program. And when we started now 9 years ago, we enrolled our first class. Well, our ninth cohort is just starting right now, but we in 2013 was our very first LGBT Health Forum. And excuse me, let me silence that. We started talking about at the time the DOMA decision, which was imminent from the Supreme Court at the time. And we've picked a topic every single year to focus on. And the topic of aging in the LGBT community has been, there all along. And we were looking for a really good opportunity and format for trying to do that. And when we, last year we did not have a forum because we didn't feel like we could pull it off with such short notice with COVID. But this year, with everyone being sort of Zoom competent and comfortable in that format, we thought that this format was actually an excellent way in which to involve a lot of people in the conversation that otherwise couldn't. In other words, those who couldn't show up in person, those who may have mobility issues or want to be able to participate that can't be there in person. So we thought it was an excellent opportunity, an excellent time to touch on the topic of aging. I know the people on this call, both our all of our panelists, as well as most of our guests, have been aware of and very, very conscious of LGBT health, aging issues, and issues for elders for many, many years. And thankfully, we're in a point right now with our government where we can get a few things done that we haven't been able to get done for the past few years. So I think all of us are pretty happy about that. But thank you all for coming. I really appreciate you registering. Special thanks to those of you who made a donation to our scholarship program. For those of you who aren't aware of what the LGBT Health Policy and Practice Graduate Certificate is, we started 9 years ago now. I created the program when we realized that there was a critical mass of need, unmet need professionally in the health sciences and the health careers and care delivery that needed to be addressed at the graduate level. We felt that there were health professionals that needed access to training and knowledge in this area. And our program, ever since it started, has been sort of an applied program, very multidisciplinary. Our students come from nursing and medicine and social work and mental health and education, a lot of different disciplines, but all focused on improving the quality of life and quality of care for LGBTQ individuals. So that program, it's an academic program, and academic programs usually come with tuition. And we do what we can to offset tuition for people who are in need. And that's what our scholarship program is about. Somewhere along the way here, as people are doing their talks, keep watching your chat. I will put the link in to make a donation for those of you who haven't. It can be $5, $10, or $500. We'll take whatever you can. I am completely shameless in making this plea because, hell, we need it. That's we'll just be real frank. So, at any rate, you probably were told this when you logged on, but this conversation is going to be recorded. So if you want to participate in the conversation, just be aware that this will be recorded for posterity and made available to participants who were on this call today. So what we're going to do, the format of this, I'm going to do introductions, just tell you a little bit about each of our speakers here. You have probably received the bios from the mailings that went out. of each of our speakers, but I'll sort of repeat that a little bit for those of you who didn't really see it. And then we'll go around the horn, person to person here, and give each of our speakers about 8 or 10 minutes or so to talk about what they've got going on in their shop. They've all got interesting things going on. They're all making tremendous impact in their particular way in the area, and they'll be able to tell us a little bit about what they have been doing and are doing in the field, and what their priorities are, what the things are they think are important for this population. And that'll get us about 30 minutes into the program, and then we'll have a discussion. There are a few points that I think the group got together ahead of time and talked about what it was we thought were important issues to discuss. We'll have a discussion amongst ourselves about that. I'll moderate that discussion. And then towards the end, we'll have some time for some Q&A. Due to the size of the group, we had over 100 registrants. So we'll see how many actually show up, but it's a little too large to have people just kind of jump in, because it'll get a little unwieldy. So we'll ask that you put your questions into the chat, or at the very least say, your name will be there, and say, hey, I'd like to ask a question about Bloom. We'll collect those questions. Our very capable assistant here, my intern Elizabeth Welsh, will be collecting these, collecting the questions, and then she'll repeat them back to me. So for our participants here, I will be making you all co-hosts so that you can, as needed, share your screens. I think a couple of you wanted to try to do that. And I will go ahead and introduce you now, just to sort of give everyone a little bit of an idea of where you are, and then we'll proceed. So starting with, well, actually, I'll go alphabetically, though. That seems to be the most sort of logical way to do things. So for our guest speakers, Carey Candrian. Carey is an associate professor in the Division of General Internal Medicine at University of Colorado School of Medicine and the Cambria Health Foundation Sojourner Scholar. Her MA is in organizational communication, and her PhD in health communication from the University of Colorado. We were talking earlier, I love Denver. I went to the University of Denver, not the University of Colorado, but very close by. And her research very importantly explores communication and its effect on healthcare, specifically its impact on older LGBTQ adults and the people who care for them. And of note, she is fairly recently on the board of GLMA, formerly Gay and Lesbian Medical Association, but now known as GLMA Health Professionals Advancing LGBTQ Equality. That is the premier organization for queer LGBTQ medical care providers in the country, and does great advocacy work. So we welcome Carey to the forum. Dee Magrini works she's at the Whitman Walker Health, and works as the director of external training at Whitman Walker Health. Also for many years headed up the Mountner Project, which many of you know is like a key lesbian group in Washington, DC. But she's been active and an activist and working in health disparities for years and years, well over 25 years, to improve access to culturally competent care and sensitive care for LGBTQ people. So her work has mostly been on reducing health disparities for LGBTQ persons of color. And she's been really important towards developing strategies to, on the local and national level to, she's really particularly interested in training and getting, educating people who provide care to elders and making them competent. Bob Linscott is up at Fenway in Boston, and he's the assistant director of the LGBT Aging Project at Fenway, which we will ask him to share a little bit about. And Fenway, as most of you know, is one of the leading advocates on LGBT issues, but on aging, this project is very, very important. Bob's work with LGBT older adults was profiled in a film called Gen Silent, which he can tell us a little bit more about if he cares to in a little bit. And it's been seen in many, many places. But his work focuses on making elder care networks that already exist more welcoming and inclusive for LGBTQ older adults. And Aaron Tax is joining us by phone today. I'm glad we could find a way to get you in today. very graciously contributing of his time, even on vacation. So we appreciate your taking the time to do that. Aaron is the policy guy, the director of advocacy at SAGE, which is, as many of you know, the premier advocate group for elder LGBTQ adults. And his history as a member of the legal director at Service Members Legal Defense Network, SLDN, was very important in organizing against Don't Ask, Don't Tell, which eventually we got to go away thanks to his help and those of others. And also served in the Department of the Army in the Office of the EEO and Civil Rights Division. And has done really terrific legal work for quite a long time and has been at SAGE for a good little time. So that's who will be speaking to you today. And Aaron, since you're on the phone, and I know it's probably going to be more cumbersome for you to participate, I'd like to ask for you to sort of go first and take your 7-8 minutes or so, and tell us about the work that you do at SAGE, what sort of your priorities are, recent successes, and things that are sort of on the radar for the future for LGBT elders.
All right, thanks, Steve. Oh, my camera's a little blurry. I'm just gonna wipe that off here. All right, so I'm going to start with what we were up to last year and how that bleeds into what we're doing this year. So many of you might be familiar with the Older Americans Act, but if not, I'll give you the very short version. It is the primary vehicle for the organization and delivery of social and nutrition programs in our country, and it funds programs like Meals on Wheels through a whole network of aging providers known as the Aging Network. So that would include state units on aging, which are pretty much state departments of aging, and area agencies on aging, known as AAAs, which are typically county departments of aging. And that law, was due for renewal last year, a reauthorization. And our goal for many years now has been to get LGBT older folks listed as a target population in that statute. And we ran into a problem called a Republican majority in the Senate, and they refused to allow us to reference LGBT people in any way in the reauthorization. It sounds bizarre, maybe strange, but they basically said you cannot, not even basically, they said you cannot reference LGBT people. That's the line we're drawing in the sand. So we had to work around that if we wanted to get anything done. And at the end of the day, we got some actually pretty good language in there, and it requires 3 things of the Aging Network. And I can get into the details of how we did it, but basically you have to connect the dots to some obscure document. And if you connect all the dots, this is what it says. Every single state department of aging in the country, and every single one of those AAAs, those county departments of aging, the 620 something of them, could be in the reddest part of Mississippi to up in Massachusetts or what have you. Every single one of them have to engage in outreach to LGBT older people. 2, collect data on their needs. And 3, collect data on whether they're meeting their needs. So that is now federal law, which is great. And we are waiting for the Administration for Community Living, which is kind of like our federal Department of Aging and Disability, to release some guidance on that. We expect that to be coming in the coming weeks or a month. And when that happens, our goal is to do outreach to all those folks in the Aging Network again, the state units on aging and the AAAs, to help them do this work. We realize you can't really just use the stick approach, but you have to use more of a carrot approach and talk to them about how there are resources in their communities across the country. Maybe it's LGBT organizations, LGBT centers, Equality Federation members, SAGE affiliates, and others, activists on the ground, who can help them in this work. So that is our goal in the coming year and beyond, is to help folks at the state and local level implement this law. And part of that will be ensuring that what are called state plans and area plans that the state departments of aging and AAAs have to file with the federal government every few years, that they are inclusive of the needs of LGBT folks and get very specific in how they're going to do this work. So we have our work cut out for us, and that's what we're going to be working on, for some time now. So that's the implementation of the Older Americans Act reauthorization. The other thing I'll mention that we're working on also with the administration is restoring a transgender question to the National Survey of Older Americans Act participants. So the National Survey measures the efficacy of the Older Americans Act in meeting the needs of those who are most vulnerable. And under the Obama administration, we and others got them to add some LGBT demographic questions to the survey. And then the one and only question that the Trump administration tried to remove from the more than 100-page survey were the LGBT questions. We and many others pushed back, got them to back down on LGB, but as you probably noticed, they really did not like trans people and persisted in keeping the trans question out. We know the Biden administration is committed to reinstating that question, and we're all waiting on a study from the National Academies of Sciences for Science, Engineering, and Medicine about how to ask SOGI questions, sexual orientation, gender identity questions. When that comes out in December, then ACL has promised they will move forward with reinstating that trans question. So that's one of the examples of what we're doing with ACL, the Administration for Community Living. I'll wrap up by talking a little bit about the Equality Act. I'm sure other people on this call today will mention it. You probably heard it ad nauseum. But long story short, is a comprehensive civil rights piece of legislation that would amend the historic civil rights statutes to include sexual orientation and gender identity across public accommodations under Title II, under Title VI, any sort of federal funding, which is a big deal, especially in the aging space, jury service, access to credit, housing, and employment. And I might have forgotten something, but that's kind of the gist. But any place you might want to navigate in your world, they would be, people would be protected. And it's particularly important to LGBT older folks who might be more at risk and more vulnerable in situations where they might not have a lot of choices. Say the one retirement community in your community discriminates. You might not be able to go to another one down the street because there might not be another one. So these issues, of course, are very important to LGBT older folks. So we are working with a large coalition of folks to get that over the finish line. And right now, wherever you live, if you can pick up the phone and call your senators, even if they're on the right side of the equality issues, or on the left side. Well, that doesn't make sense. Right or left side, but I meant like on the good side, pro-equality or even anti-equality. It's good to pick up your phone and call them to thank them for their support and encourage their leadership if they're with us. And if they're not with us, to encourage them to support us. And that's where the name of the game is now, is getting to 60 in the Senate. So perhaps I'm happy to speak more, but I will stop there unless you have any questions at this time.
Yeah, we'll circle back to the Equality Act because that ever looming 60 to stave off a filibuster and the future of that is it's always hanging in the air. But it's the House obviously has been a little bit of an easier task, but we may circle back to that later. And I appreciate your phoning in from vacation.
Sure.
Really, as long as you can hang on, we're happy to have you for the rest of the discussion.
Yeah,
so,
I'm probably going to jump, but I appreciate the opportunity to be here.
I'm really glad you decided to join in from vacation.
All right,
so,
thanks, Steve.
Thanks for calling in. Thanks.
See ya. Bye.
Bye. So Dee, I actually want to go to you next because Whitman Walker. Well, I remember the Mountner Project when you were making that happen for all those years, and Whitman Walker sort of met your teen aides, and Mountner sort of became a part of the same organization there, and you've been doing great work for a super long time. And I haven't really had the opportunity to hear you talk about what you got going on over there, and this is perhaps a special chance to talk specifically about what's going on for elders, particularly elders of color in DC, and also training and stuff on a national level as well. So yeah, love to hear what you have to say.
Okay, great. I doubt if I have 7 or 8 minutes, but I'll share what I do have. So Dee Magrini here, pronouns she, her, and hers, native Washingtonian on this land. Yeah, when you say 25 years, Steve, it seems as a moment and as a lifetime, all at once. But I was lucky, blessed to walk into the work that I walked into, really around women's health and then lesbian health in the 70s, really out of the free clinic kind of feeling and movement of trying to assure that women had a safe and competent place to go for care. And that sounds like a no-brainer, but it really is not. 20-some years out, that we haven't taken care of all the issues that need to be taken care of, just in that vein. But that's kind of how I started doing this work, and realized pretty quickly that if women writ large were struggling, lesbian women, bisexual women, and trans women, but not in that terminology at that time, were really struggling. So that became kind of the platform I was working from. And went to from a women's health collective to lesbian services, which was part of Whitman Walker Health at the time, and learned how to do really what I think of as guerrilla women's healthcare. I mean, it was go out with a bag of whatever you got, say for sex equipment, whatever you got, but be ready to meet whatever challenge you found. So, do you know about breast health? I can tell you. Do you know where to go? All the connection had to be within a person. We had the internet, but that was still really tiny. And a lot of people didn't have use, didn't have access, which kind of reflects where we are today with a lot of our population. Is there, but who has it and who can adequately use it? And Steve, as you know, from Lesbian Services, the Mountner Project, which really was a jolt for me because I had gone from this kind of scrappy, we're going to go in the street with bags, to a really professional environment, and trying to catch up on the language of that and on the skills and the programming around that was a quick and hard learn, but I can't tell you how pleased I am that that happened for me. But again, the view continues to widen as you move. And I realized that many times I would go into rooms like we have here and be the only person that looked like me, over and over again. And so a lot of my work today has been about why do the rooms look like they do? And how can we collectively change that? Because I can't get the rest of what I want to get done unless the room looks different. So when the room looks different, how do we create trust in our communities that we can offer something? How do we make the same partnerships that I talked about in that Guerrilla Girl Health thing where we are now to reach the communities that we're talking about? I see Black women, I see Latino women, women of all kinds of races and ethnicities, not connecting around the language that we use around LGBT health. Even the LGBT is like, what? When will you speak to me? And I say, I speak to you, but tell me how you want me to call you. What is your name? And give me some meat under that. What that means in the position I hold now is to hold your hand in that professional way and be able to deliver trainings to doctors, nurses, social workers across the continuum, but hold community's hand as well. How do I stay true on both those ends and get real information, still be part of community? I'm an elder myself. What issues am I confronting as I go? Trying to maintain health in this time. It's challenging. And I will say, without an advocate, if I did not have the work I have now, I would be in bad shape trying to figure out what to do. Not just for myself, but I have an elder mom. What's all of that about? How do we take care of each other? How do I make sure we both get a good deal? So I come to encourage tonight. I come to encourage the thing that probably you felt early on or feel now, is a sense of constructive uncertainty. I want you to go into communities you don't know well. Take a friend, but learn how people want to be called. All the education we can do will not be adequate if we have not taken all of our family into consideration. So I'm glad to be here with you all tonight, and thank you.
Thanks, Steve. Really, and I'm looking forward to hearing more in the discussion part, particularly to talk about training and all of these, elder care facilities and what's out there. I think there's a lot to be done, and I'm looking forward to that talk. Bob, from from Whitman Walker to Fenway, from DC to Boston, you have a project going on up there that's quite remarkable. And Fenway's got some great stuff going on. But perhaps you can tell us a little bit about what you've got going on with the Aging Project at Fenway and sort of what your priorities are up there.
Sure. Thank you for having me a part of this. This is a great honor. I'm going to jump back 20 years and say in 2001 in Massachusetts, we realized that there was a huge gap that our elder service providers were not thinking about the LGBT older adults, and the LGBTQ community were not thinking about older people. The queer community is just as youth focused and youth centric as the mainstream community. So we realized who's falling down in the cracks here is our most vulnerable population and our greatest asset, because our connection to our history, our community, our culture, our past, everything that we have done is because of the ones that came before us. So the summit was called together and brought together community leaders, elder service providers, faith leaders, all these folks, and to look at the situation in Massachusetts. And what was decided was the creation of an organization that would be called the LGBT Aging Project, and then we are now becoming the LGBTQI+ Aging Project. But that organization would be the primary model for providing the training for all mainstream elder service providers to make sure that they were inclusive of the needs of LGBTQ elders in their service delivery. And so instead of creating a whole separate service delivery, to make sure in Massachusetts, we have a really good elder service network with ASAPs, AAAs, and councils on aging and senior centers and that, and Meals on Wheels, all that is out there. That's great. So let's make that inclusive, that existing system inclusive of our community. So then that created a whole need to do cultural competency training. And this is the time that people weren't doing that then in this. And so we created a cultural competency training pretty much a similar time as SAGE was doing their model in New York. But one of the things that has been unique for us is because we are a smaller state compared to a lot of outward focusing that folks like SAGE are doing, is we were able to develop relationships between the elder service providers, because you can't go in and do a training and then give them this lovely rainbow sticker, have them plastered on the door, and think that the queer community is just going to line up behind. Hell no, excuse me. They're just not, because of the history of stigma and discrimination and that distrust of mainstream institutions that has just done them wrong for so much of their lives, thinking like pre-Stonewall and all of what's going on, and people could be committed, they could lose their jobs, their housing, everything. So, just the fact that they see a rainbow sticker, is great. But so what we ended up doing was then working in partnership with these organizations to we became a bridge between the organization and the LGBTQ elder community. So we do community conversations, get folks on board, and then slowly find ways to create programming so that there could be something ongoing in that community for older LGBTQ older adults. And so what that has grown to is, here's an example. We have Aaron was talking about the Meals on Wheels and good congregate meals. And so in Massachusetts, we have a calendar. Of course, this is like frozen in time now. So it's like the last one was like right before the pandemic. But we have 24 LGBT-friendly community meal programs all across the state. So there's something in just about every region where folks can come to meet other LGBT folks, come in, get a hot, nutritious meal, have socialization resources. But the most and critical thing is to know that they have they're building a connection and they're aging with their provider, over time. And that is really critical. So when the time comes, they know where to reach out for home care or, bereavement assistance or, protective services or anything like that. That has really made all the difference in the years prior, when there was such a fear and distrust, thinking that they're never going to understand us. I'm not even going to bother. So I can say a little bit more. We've continued to hit the ground and pushing and pushing and pushing. We had, and which I can talk about later if folks are interested, but we had a push to get the first in the nation of special legislation, statewide legislation on LGBTQ aging. So we have a LGBT aging commission, governmental commission, so that looks at all aspects of life in Massachusetts, from policy to long-term care to senior centers, everything. So that's been going on. And then one of the first things that we were really focused on at the beginning of the commission was to get legislation passed to have a mandated training. So every single elder service provider who is funded by or licensed by our, Executive Office of Elder Affairs would have to take that. And that is huge, because prior to that, everything that we offered at the LGBT Aging Project was optional. So we were so happy when people reached out and said, "Oh, we're dying to do this. Can you come do this?" That's great, but we wanted to go where people didn't want us to go, because those were the folks that said, "Oh, we don't have any gay people in our town." Yeah, right. So now everyone's mandated. So that has got passed, and that just started kind of unfolding right at the beginning of the pandemic of that training. I can talk about that a little bit later. And Ms. Stephen, as you mentioned, we had the great fortune way back 10 years ago, and I can't believe 10 years ago, where a director was there and really interested in the work we were doing. And we had a conversation one day, what would it look like if we made a film about your work? And so little we know, that would be the #1 tool that has gone all around the world and back again 10 times over to talk about LGBT. Like, it's so dated now, but it really put faces and names, and the fact that we could have, really strong spotlights on elders of color, on trans elders, all of that in one film was just unparalleled. So I think that was that really put faces and names on the map and gave people something to talk about. And especially when you would show that in a community, in a mainstream community, in one film really suddenly puts everyone on the same page. They understand it, they get these issues that we're talking about. So when we go into discussion later, I'm happy to also talk about issues around some of the big things we're looking at right now is around housing, getting housing issues going up, but also now that we have hit the pandemic, how's that changing in the work that we do, and what does that mean about this sense of connecting people when we have all of these, and then overnight that they turned into nothing. They just so I can talk later about the work that we're doing of keeping people connected online, and now moving into this idea of hybrid programming, whole new field. So thank you. And as again, I said, it's an honor to be here, and I look forward to hearing folks' questions later. So thanks.
Bob, thanks for coming. I really appreciate your giving your time for this. And regarding the film, I'm never ever surprised by the power of the media and how much it just people resonate with things they see. They get personal stories, they feel like they know real people, and it doesn't surprise me at all that film is sort of carried a lot of what you've done. That's really fantastic. So Carey, I'm really dying to hear more about what you got going on there, and your research, because it sounds like really, really critically cool research. And a lot of people here are in the applied field, but the critical research that goes on to back up what we do in the applied side is very, very important. But yeah, love to hear it.
Perfect. Well, thanks, Stephen, and thank you all for coming in. I'm really delighted to be here. As Stephen mentioned earlier, I am an associate professor at the University of Colorado School of Medicine in Denver, actually in Aurora, and then a recently new board member at GLMA. I teach and direct actually the communication curriculum. We have a Master's of Science in Palliative Care at the University of Colorado, which is an interprofessional master's and fellowship with physicians, nurses, chaplains, social workers, and allied health professionals that come through the program. But primarily my role is really around research, the way communication affects the impact that communication has on healthcare, and particularly its impact on older LGBT adults has been my primary focus. And really, I've spent most of my career evaluating what happens when an open discussion with patients about who and what matters is avoided, especially around end of life, which has been my main area of focus, those living with serious illness, and then particularly the intersection of hospice and palliative care. Just I can tell you about some of the projects I have going on and we have going on in Colorado. One of them I'm partnering with the National Hospice and Palliative Care Organization, NHPCO, to train hospice nurses, particularly the admission nurses, to routinely and sensitively collect sexual orientation and gender identity information, with the goal, of course, to collect the data, but even more so to actually ask these questions in a way that does not perpetuate disparities, but leads to an open discussion about really who and in what matters, which becomes so critical around serious illness, particularly around the end of life. Another project we're working on in Colorado that has been probably the most challenging is we are working with Christian Living Communities, which is an assisted living organization started in Colorado, but now stretches into Texas and Utah. We're training 860 of their staff, which are across 6 of their locations. We're using SAGE, but as a precursor, because we've had so much pushback. A lot of what Bob said, that there's just adamant that these residents don't exist. This is not an issue to focus on. They follow the Eden principle, so they do a lot of like garden analogies. So right now we've been warming the soil for about over a year. And as a pre-thing to SAGE, we decided to create this video, Caring for All, Opening Hearts and Minds, that the same 860 staff will watch first to warm the soil, and then they will actually go through the training with the goal that hopefully this will actually stick and that they will hopefully have some opening of hearts and minds. And in the video, we actually are going to be filming the next couple of weeks. We have actual residents across these 6 communities, 2 staff members, and then the new CEO, who's actually been a great advocate, talking, and then actually the chaplain, who's been another advocate of making this connection. So we're hopeful that will lead this project to success. Another project that was recently finished that was funded by the Lesbian Health Fund. It was a qualitative project and a community-based participatory research project. I interviewed 31 older lesbians in rural and urban parts of Colorado to really better understand their needs around aging. And a lot of what came out was just the lack of resources and support resources in particular that were designed specifically for them. As I mentioned, I live in Colorado. We do not have an LGBT specific grief group or support group anywhere in the state. So that has been one thing that has come out of that grant, is actually the creation of a grief support group specifically designed for older LGBT adults. And then the last project I think I'll mention is an area that I've become particularly interested in, sort of an understudied subject around the intersection between older LGBT adults and Alzheimer's and related dementia. So this was, again, it was a mixed method study. It was extremely difficult to find participants, but we ended up interviewing 21 caregivers across the US, really, who were caring for their partner who was living with Alzheimer's or related dementia. And out of that, really one of the goals was really just to sort of begin to map the structural barriers that so many of them face and the impact that these barriers have, whether it's not having surrogate decision-making laws in their state or even non-discrimination policies, the impact these have on their experience and outcomes in the context of Alzheimer's and related dementia. And one thing that I think is also that I've become particularly interested, being a social scientist and focusing really on the relationship between inequalities and the way we communicate, is also the gap in policy and education. And that has really become even more so illuminated with the Christian Living Communities. We actually, we have pretty robust non-discrimination policies in Colorado. We have a gay governor. And just last month, there was a woman who identified as trans. She was denied 65 times in Colorado looking for assisted living because of her gender identity. And so we have a movement to, even though the policies are in place, to actually have the education match so people know what these policies mean, what is allowable, what is not allowable, and follow up with the staff so they know how to actually enact these policies in a way that leads to equality. So I'll end it there. I'm anxious for the discussion. I don't want to keep talking, but thanks again for having me.
Yeah, we'll circle back to a lot of that. So thanks for bringing us up to speed. And actually, I do want to stay in Colorado and your observation about the challenges there, because we were talking before the program, but you know, I went to grad school in Denver, at the University of Denver, a different school, but you know, very close to Aurora, where the medical school. And I went to the medical school to do a lot of my, you know, studying back when you actually had to go to a library to get resources and photocopy them and all that sort of stuff. Denver really is, Colorado, the state rather, is a study in contrast. You know, you've got this, you know, Denver is this like sea of blue in the middle of this vast ocean of red, you know, down south in, you know, just south of us a little bit, where you know, focus on the family, and you know, a lot of conservative think tanks are in Colorado Springs. And you know, Jared Paulus has been it's amazing, but you know, he was elected, and yeah, I knew him when he was in Congress, and he was trying very hard to get you know, some legislation passed, you know, before we had the idea of the Equality Act and something like that. ENDA was hitting roadblocks along the way, and I go to that because it was this religious exemption thing that constantly got in the way of ENDA, and you know, that has always been a thing, and it's sort of, you know, Denver seems to be a microcosm of what's, excuse me, Colorado is a microcosm of what goes on in the state. I'm just interested in what the challenges are, as the way everyone sees them, you know, regarding the religious right, regarding conservative thought. And, you know, the fact that a lot of care providers are, you know, maybe conservative in orientation. A lot of them are religious based, Catholic based. You know, they you know, the laws as they may be, you have to get them into practice. And, you know, Dee, I know you really focused on training and getting people educated. And, you know, what I mean, maybe we can talk a little bit more about the challenges that exist there, not just in Colorado, but across the country, in getting these care providers that really do have an ethical obligation to take, you know, good care of our population. But jump in, whoever wants to.
I'll take the first leg. You know, policy helps a lot. Law helps a lot in this vein. And DC actually has something to stand on, that providers need 2.5 hours of training around LGBTQ health for their license. Okay, great. I'm starting to see people, you know, folks really coming through. It's been a few years now, so we've been training folks, and I'm trying to really read the difference in attitude and buy-in from when folks were just buying the program or asking us to come because they knew they had a need, versus we know we have a need because there's a licensure thing. And so far, I'm not reading any difference. But I think the focus of training within organizations, to go in, I try to really encourage agencies to look at more steps than one, and who they're talking to. All staff, if you stick all your staff in a room and say, we're going to have an LGBTQ training, there's going to be some folks that will benefit and some folks that will be asleep, because it won't be a training for the work that they're doing. I'm really concentrated on home health aides and trying to find a good way, a respectful way to offer training to folks that may not be from this country and may have already suffered their own indignities in terms of how we once employ them and use their service. So how do we talk to you? And why do we assume we know what you're thinking? Because often when I go into agencies, they say, well, you're going to have a problem with these folks. And so there's this class separation, often a racial separation, but a real class separation on how we're viewing those folks that are doing the most intimate care of our loved ones and ourselves. So I'm really looking at that. And that is, I mean, it does feel like splitting hairs, but honestly, the best education I've ever gotten is when someone's talking to me about the thing I need to learn. So we're trying to calibrate all of that stuff. I would say the thing I find now, one, is really not being alive to your topic each time. the pandemic has created a situation where I do a lot of my work from where I'm doing it from right now. Okay. I was worried about that initially, like, can I reach you from here? And I think sometimes yes, often yes, but it has to be a real thoughtful and timed kind of situation. I do think that, you know, recorded or more structured, not more structured, but repeatable trainings that are recorded can work for folks, but for me, if I can't read the people I'm seeing, I don't know what's working or where I should massage that a little more, where I should turn the page. So I'm really a proponent of getting in the room with folks, making a connection, a partnership with agencies, getting in the room and then repeating it, coming back. You're gonna have new staff, your management needs, just trying to get in there and build a real partnership. So even when you're not there, somebody's got a question, they pick up the phone. Somebody's gonna know that over there. Excellent, excellent. There's one other thing, and I feel like it's slipping my mind now. Well, I will tell you that one of the, it's not a pleasant challenge, but it's being incredibly interesting for me, is I, you know, came out as a Black nationalist and as a lesbian about the same time, which was was a struggle. This was in the 70s, so it was not easy. And I've had an interesting time bringing those things into alignment for the rest of my life. How do I be all myself in all the places I am? And if I can say that that's my legacy goal, is to create that for someone. I do what I do because I feel like I have all of you with me when I go for care or when I go for whatever. I built up some skin and I can do this thing, but everybody's not there. So how can I help you see, even you all, help you see more than, if we just say LGBT, who do we think of? We're not thinking of seniors. We're not thinking of a lot of us that are on this call. We have to interject that every time. And I will tell you, Bob, I saw your face and I was like trying to bring it back to you. How do I know this person? How do I know this person? It's the film Gen Silent. I will tell you, you have been my training partner in some ways for a long time. I'm so happy to thank you and know that one of the methods I've used for our elder piece is to use the life stories that come through in Gen Silent. So that's the softening. And then what people are talking about now is the retelling of history, but telling history in a full breath. So how do I bring our heroes, our icons back into the story of history? I've been here, you know what I'm saying? So generally I start from like around World War II and just read people back into the text. This is who we are, and make it real big and real human. That's my end of what I get to do, and it is an honor. Also, I spend time talking to PIs about how to reach into communities of color, how to reach into communities of color that are LGBT. And answers, I don't have any, but some of it is about holding the conversation past that constructive discomfort, past that uncertainty, like please say the words, have the thought, go on until it stops making you itch, and then we can have a real conversation. Yeah, I'm gonna leave that there for right now.
I just wanted to jump in and just say a couple of things to relate, because Dee just brought up such a really important point. And for all of us that are engaged in this work, is that when I have to use a Hamilton term, when you're in the room where it's happening, you can see the people, and you can, I love Carey's thing about warming the soil. You can warm the soil and you can realize where you need to put a little bit more steam and a little bit more heat and where you can back off. And But when you are trying to do broad strokes and train large numbers of people, that's really frightening to do a module. And so when we got our bill passed and that became law, and we're thinking this is going to be, you know, upwards of 200,000 people, and there's no way that Lisa and I can get out there and do in-person training for 200,000 people. We have to go to a module, and we know what modules are like. Everyone has got this down to a science. Everyone's got to fill out there so many modules for everything from HR to this to internet safety to whatever. And you just know, click, 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 click the screen, take the quiz, click, click, click. And if you miss it, go back, read it again. Then, no one pays any attention. None. I don't. When those things come, I don't pay because my time's really important. So we thought when we've got to do this training, this has to be different. It absolutely has to be different. And the thing that I think changed for us was the fact that we had the experience of Gen Silent, and we knew that that film changed hearts and minds. And so if we could find a way to get there and make this 1 hour module the most interesting thing that people had ever seen before, then that's what we're going to do. And we found an organization. I think this makes it sounds like exactly what Carey, you're heading right down the same path there, which I think is great. But we found an organization in Toronto, Baycrest, and they have seniors who role play, and they also have their own staff there, doctors and whatever like that. They role play scenes. So we gave them the exact scenes of what was happening, of case situations that happened around LGBTQ issues. And what we did was we would film 3 versions of it. One was like the most cringeworthy, awful, worst practice of what you would do in a situation. One was like, okay, if you're just learning this here, this one's passable, but here's the last one will be the best practice. And to see that played out. But the thing that you need to speak with, and Dee was also mentioning this too, is when you're thinking about the people that we are most concerned about, our most vulnerable folks, who is doing the direct care for them? A lot of times, as Dee said, these are folks coming from countries where homosexuality is against the law. You don't even speak these things. So they feel like they have the great intention. They're going to save them. They're going to bring the Bible. They're going to do all this stuff. We had to have Haitian and Creole, whatever, actors talking about one, how like, oh, I can't do this. I'm not going to, oh my God, she said this. And the other one saying, hey, no, this is our work. This is in the way that they describe what needs to be done and kind of get them on the same page. To say, for folks to see that played out has really been a huge change agent for us going forward, and to make this, hopefully that, because we can't see, as Dee said so beautifully, like you can't see people, like you got to just hope that this is having an impact. The folks that this has rolled out to so far, the feedback we're getting is phenomenal, that they're actually watching and listening and going back and doing it again. The fact that some people say, I did your module several times, I'm like, what? So that's good. If there's something in there that they want to see again, then they're going to go back. So hopefully that's going to be a through line for us of thinking about how we're making a difference. The other thing that I meant to say before, if I can just jump back into kind of giving you the broad overview of what we were doing, is recognizing what I think is really interesting is that looking at the history of these kinds of trainings and the issues that we're talking about and the beginnings of, like, I think folks are pretty much understanding the L and the G in terms of our acronym now, but thinking about now, where's the learning curve? And the fact that we absolutely need to be talking about diversity, equity, and inclusion, who is not at the table, and making sure that all our programs are really diverse and people are feeling welcome, because there's just as much racism in the queer community as there is in the mainstream community. We've got to come together. We've got to address this as soon as possible. But the other place, when I was saying, when you're thinking about our most vulnerable people, like, where do they want to be? They want to be part of a community. They want to be able to go to a senior center, and it's their peer. People have forgotten that training also has to trickle down to their peers, because those are the people that were harassing and bullying them and calling them the names, because they never had any diversity education back in the 40s, 50s, 60s, 70s. There was none of that stuff going on. So we're really engaged right now in doing a lot of training programs that is working with unconscious and implicit bias to understand, where do you get these ideas about lesbian people, gay people, and we're doing another whole separate one around gender diverse folks. So people can really understand, because that's one of the steep learning curves, especially with our elder non-LGBT folks. So I just want to add that in.
Fantastic comments. And you made me think about a few things that Shane might have said if she was on the call. And Shane Snowden was to be moderating the panel, and unfortunately she couldn't make it tonight. And so I pinched it for her, and I told her I would do the best I can to rep. But you know, in terms of reaching these people, it's, you know, you talked about the training modules, and oh God, here comes another DEI thing I got to go to, and all that sort of stuff. And you know, it's her approach, and I think the way that film works, the way that, you know, you talked about the film, and like, you know, just it's got legs, and it's making an impact. And when people see, you know, real people that they can, you know, feel like, you know, my contention has been marriage equality attitudes turn because everyone suddenly knew someone who was gay, or had a parent who was, or a son who was, or whatever. When you hear real stories from real people who are likable, and you can disarm people in trainings. You know, one of the things we wanted to talk about here was training and reaching people. There was a question in the chat that came up very early, was about most of the focus has been on big cities, and, you know, how do we reach people outside of those big cities? And, you know, frankly, the program we run here at GW, the LGBT Health Policy and Practices, is, you know, our challenge is we made this a hybrid program so that we could train people, you know, we could reach people who are in rural and southern parts of the country that, you know, we preach to the choir here in Washington, D.C., you know, D.C., Boston, San Francisco, and New York. And we're seeing the same people over and over again. We aren't reaching the people we need to. So when you have the opportunity to get to them, you know, it's very important to understand how do we make them, you know, like us, and we can disarm them by not being the stereotypes they expect, by being real people, by being, Shane likes to talk about, you know, when she walks in, they're going to expect, you know, a man-hating lesbian in Birkenstocks who, you know, rants against, you know, fills all those stereotypes. And when people realize that, you know, they're talk about, you know, what we really care about, not, you know, statistics about, you know, this, that, and the other, what the social determinants of health and health disparities are, but about what we really feel and care about as Americans. And I, getting even closer to an elder American, it's very important to tell, I think, our personal stories. And I think that, you know, it comes across in, you know, the film you talk about, and I think that may be how we reach them. But I don't know, anyone else want to talk about, like, you know, how do we address this problem of people that don't want to listen to what we have to say?
I'd like to take a run at it and tell a little tiny story. Early in my training career, my professional training career, Mountaineer got a call from, and I can't remember the city, but it was in Texas, okay? Texas, and this was like maybe 1995 or something like that, around there, I can't remember. And they wanted someone to come down. They knew we had this training. The CDC had helped us develop, supported the development, and funded removing the barriers, which is a huge, you know, kind of spine of LGBT training. They have found that and invited us down, but what they wanted was, we want you to come and talk about lesbian health and LGBT health, but we don't want you to send a big scary lesbian with a belt buckle and tattoos. I mean, that was actually part of the ask. I'm the trainer. I was the trainer, and I'm incredibly tattooed. But I was able to go with what I call my little tattoo blanket. I covered the tattoos, because I want you to hear me, and I know I'm already creating enough static as it is without breaking into it. Just, you know, I don't want to, there's no point in pushing the point. But I realized, I think in that training, that my job, the tendency is to try and get people to like you. I on a personal level, I want them to think I'm a good trainer. Liking is a whole nother thing. It's the humanity I'm after. I don't think you have to like everyone or see yourself in a real granular way in everyone. You just have to know that some of the struggles and some of my emotions are like the ones you have, which is what Jen Silent does. It shows you loss, it shows you joy, and we all have those things. And that's the launch pad for me. So no, I think for me, and this is just my training style and how I view this, I think that the road to likability is not the one I want to take. The road of dignity and humanity is where I want you to see me, because that is the duty you stood up for. I'm an ex-military person. You hold your hand up, that's what you do. So I don't need, the liking thing, it'd be nice, but I don't care. All righty.
Yeah, well, there's something to be said for, Carey, I think you had something to say. You go ahead first.
No, go for it. You were.
I was just going to say, part of, the social psychologist in me is coming out. I'm trained as a psychologist, right? And likability is one of the ways you like make connections and can influence people. So the tenets of social influence have partly to do with having likability and just but I don't think they have to like you. Like you say, you want to be respected as a trainer and want them to know that. I think just being sort of a genuine person and not an automaton, or it's we all dread trainings that we know are just cold and dry and sterile and offer us nothing new. And I think the more we connect on a personal level, and one of the ways you do that is being likable, or at least not dislikable. I'll put it that way. So anyway, yeah, go ahead.
I was just going to add a little bit more about what, I mean, as painful as I talked about the experience in the soil warming, it has actually been it has been really instrumental in really understanding what is happening, especially as you mentioned, Stephen. I mean, it's 3 of them are in Denver and Sloan's Lake. I don't know if you remember. I mean, they're pretty central Denver, and we've had this, it's made me realize though, just, I mean, how different the worlds can be and how much it impacts the ability for this training to actually even work or even have them be receptive. And I'm grateful that it's taken this long, because I really feel like once we finally at least show the video and then eventually get to the SAGE training, they might be at a point that they might be able to open up. And I've even joked, I say, like, if we can do this in Colorado, we can do this anywhere, because it has been just this belief that, and that was like part of it. We couldn't even say the word LGBT. I mean, many of them really thought that there were more gay people because people were eating more organic in Colorado, that we really had 3 eyes. I mean, it was crazy. And I would leave them thinking, like, I cannot believe this is happening, like in where I live. And I mean, very close, and like thinking how much progress is made, and yet how reversed it can be, or just at such a standstill. And I think the one thing that we've really seen work is that people change people. I mean, I gave them every statistic you would think that would move them to think that, because they were adamant that this was a choice that people did and they should just choose not to. The statistics did nothing. But when they realized, like, they knew that I didn't have 3 eyes, I think, and for many of them, they hadn't met anyone who even was LGBT. And I think that has been part of it, is that the religion has been a huge barrier, but we have had great champions, which I think is essential to be able to do this, especially within religious institutions. Like having the chaplain speak has really been fantastic, but also the debunking of these myths that people still have and think, and this like really underlining discourse around, we are open, we treat everyone the same, we're inclusive, yet they've never actually interacted with someone who is remotely different from them. So that has just been part of it too, is actually being in connection and making them realize, 1, we exist, 1, we don't have special dogs, we don't do special things. And then also like this hearing that, knowing that people exist and are that they're neighbors, because I think the staff is a problem and the residents are also like even more sad, and they're the ones that are having coffee every morning and things like that. But think my point and all that has been a great learning experience, because I think you get, you feel that we're moving so much forward, and we are, but then you remember and being connected to these communities where so many of them are living, and you realize how bad it still is and how much change still needs to happen.
And I think in religious community, I mean, one of the things that really, emboldened me and made me feel really optimistic was, early in the course of developing this program, I was asked to give us a talk, keynote talk at Princeton, on Princeton campus too. These were hospital systems that were run by religious, religious, so mostly Catholic hospitals and such. And I do my best to make it fun and all that, but I realized, this is a situation where I was not preaching to the choir. These were hospitals that were bringing in people who were very conservative and were skeptical. At the end of the day, I used, when I explained the acronym, because I knew I was, not speaking to, members of our community, but those potential allies. There were some allies and there were some potential allies, and there were definitely some antagonists. And I mentioned the word queer, the Q as the Q in the queer, and a woman came up to me afterwards and was really angry with me for using the word, because she said, queer, that's a pejorative, people, that's an awful thing. And one-to-one I explained, well, this has sort of been, we've recaptured it and we've repurposed it and we've taken it on as ours, and this has got a completely different meaning. But in my conversation with her, this was a person, was many years my senior at the time, and she explained to me, it's like we get it, we know that we want to do better, and she said 20 years ago I would have said, this is stupid, these people aren't here, and they don't matter. But they really want to do better. There's enough of them there. There's a critical mass of people that, they aren't in our camp. They don't understand it, and they want to do better. And the personal stories, and like you said, if they know someone who's gay or know someone who has a parent who is, then they really want to sort of make that change. And they're open to it, and they will listen. And I mean, nothing makes this point. My parents surprised me, I mean, this is just one personal note, and I'll let people take off. And I want to go to one question from the audience here in just a moment, because this is very relevant. But, in 1976, my parents sent me to conversion therapy. My mother called me this past Sunday, and so proud that their Episcopalian church, they hired a new priest who is a gay man and has a husband. And she was just excited to tell me about it. That's the kind of change that can happen in, those are 50 years, and my mother's a very religious, very conservative person, but she got it, and I think we have some hope there, and in a lot of these places. So I wanted to go to it's a sort of question time anyway, but and Max, I'll just ask you to speak up, because I know you're from a very rural part of Pennsylvania, but I think you had a question for the panelists regarding rural populations. So I'm going to ask you to turn on your mic and ask your question.
So I am a 2021 graduate of the program. I just graduated. So I'm just going to really quickly run through a couple of things. Bob, I love the work that Fenway does. I served on Fenway's board of visitors for 5 years, and was the director of prevention, education, and screening services for the AIDS support group of Cape Cod between 2005 and 2016. So I love everything that Massachusetts does. You guys are on the forefront, and Fenway. I love Fenway. So Dee, I love what you're doing in DC. As my capstone project, I created the LGBTQIA Cultural Humility course for DC's fire and emergency medical service providers, and love what you're doing. And Carey, I have a very special place in my heart for Colorado and Denver. So I love what all of you guys are doing. What Steve just mentioned was, and where I want to get to my question, is that I spent, although the fewest years of my life, the most important years of my life, from the age of 9 to 17, in southwestern Pennsylvania, where my family was from. And it was a very rural community, a coal, steel, voted 77% for the Republican candidate in the last election. And I did a lot of work there. As part of this program, I helped to found the first LGBTQIA support group in that county, Somerset County, Pennsylvania. And this Sunday, I'll be attending the very first Pride event in that county. So my question to you, and I know that you're all working in metropolitan areas, but my question to you is, what's the state of LGBT care and support and whatever in rural communities in America? And where do you see where we can help develop services in those areas?
I'll jump in and just say one quick thing, because you speak to something that's so important. And it used to be that it was the old myth that everyone needed to, travel to the big cities to be themselves, to find their people, whatever like that. Maybe that was great when you're 20 and 25 and 30, whatever. But once you start past 40 and 50, like, who wants to do that kind of driving? And then at first, our seniors can't. So the real ticket is to reach out and kind of create coalitions, create regional programmings with the senior centers, the councils on aging. If you're trying to get, if you're trying to find a place where people have a sense of belonging, because the data is not good still. It's getting better, but it's not good for our population, for our community. So many folks are still aging alone. They don't have families. That's definitely changing, but our current population of elders, really, so many of them are aging alone, don't have those, they're not connected to their families of origin. And so we're dealing with a lot of horizontal caregiving, a lot of folks who are their circles of friends, 178, 176, whatever like that. So the more that you can get in and really get your councils on aging and senior centers on board and create programming, and they're going to say, well, we don't have enough in our community to do programming that great. Bond with the three communities around you, and everyone take responsibility for 1 week and do something and allow folks, because traditionally folks will come, and when they go to a program that's offered in a senior center that's an LGBTQ program, they really often aren't from that community because it's too frightening for them to come into their own community, to their own senior centers, but they'll travel 1 or 2 towns over. That is really what's taking off, or in our rural areas here. There's nothing that's happening. Those folks are not coming into the city. They're not going to deal with parking. They're not going to deal with public transportation. They're coming here. The other thing that's really critically that we're all learning in this pandemic world, pandemic weary world, is we have opened up a new door with this getting folks online. And the more that we can find services, and through the American Rescue Act, all of these senior centers have funding now to get devices into the hands of seniors. And so the more that you can get folks and train, because we had to do this literally pivot overnight with all of our programs and get folks trained on Zoom. I used to have a full head of hair before the pandemic, but trying to teach seniors how to use Zoom in a matter of a few short weeks was crazy making. But once you do it, you'll never go back. Now we've leveled the playing field for disabled people, for homebound people, for people that are in assisted living. Like, everyone can connect in. So if we can get them connected in, that's good. And if you can reach out to those senior centers and COAs and really try and get some allies on board that will do some programming there, then that's a great first step.
Yeah, no doubt, no doubt.
Thank you. Thank you for that.
Yeah, great questions, Max. One thing I think from a research perspective, how it just underscores how critical it is for those of you who are engaged in research to include folks who live in rural areas to better understand what actually are the barriers of facilitators or their needs is absolutely critical. I mean, if we're not including the people who we're trying to serve in the actual research, it's going to be really hard to tailor these services. One thing that has been Colorado, I do live in Denver, but we have some very fascinating rural parts. Some of them have actually developed really robust communities just within, I mean, their families of choice. And so I think in Movement Advancement Project, they're based in Boulder, do phenomenal work. Recently released a report on rural life for LGBT older adults. And then the other, and I also, to Bob's point too, last Thursday, we called a lot of our senators in Colorado with the NHPCO advocating for telehealth legislation that's in the House, in the Senate, and then the community-based palliative care demonstration that would actually help reach out in Pacheco too. These services, which would then require, though, they also receive training, but things I think are moving in the right direction with a big eye on seeking those that aren't living in more cosmopolitan areas.
I just want to push one more time at this, and you know where I'm going, that programs are wonderful and we do good work, but you know that it is incredibly difficult to try and build in diversity after the program is already built. Please, please, please look at our staffs, look at what we're thinking, look at how we're building a program, and then we don't have to back up in order to serve everyone.
Yeah, and that's essentially what you know, Max is who just asked the question there not long ago, whose capstone project was building this training or for fire and emergency management services. And I love the acronym FEMS in DC. It just works so well. You know, it's that the need for that resulted from a, you know, really tragic and horrible situation with a woman, a transgender woman who was poorly treated and in fact, you know, paid the ultimate price for bad training on the part of the department. And, you know, we you know, some institutions and you know, we talk about institutional racism, institutional homophobia, transphobia. We have to retrofit them somehow. It's great to build programs from the ground up that are, you know, inclusive and progressive and all that. But you know, some institutions and, you know, the conversation about police and policing but also emergency management and emergency response. There's just endemic racism and homophobia and transphobia built into a lot of these organizations, and that's why Max's training was so important, because the DC Department of Health asked us to work on developing this for them, and Max rose to the occasion. So thank you so much. The city thanks you, and I thank you for really coming up with a great training. But you know, and I see not just for emergency response and police, but you know, elder care. There was a great question here, you know, backing up a little bit from Lorraine about sort of like the difference between types of caregivers. You know, those who can afford to pay caregivers and those, you know, maybe those for the state who are poorly paid. You know, how do we train them? How do we get into those sort of cultures where you know, the transphobia and homophobia is just really, really pervasive. These are big challenges. Anyway, I'll shut up. We've got about 10 minutes, so we can keep talking, and I'll look for stuff in the chat. But yeah.
I'd like to ask a question.
Thanks, Linda. Go ahead.
This is very informative, and I thank all of you. I teach a course, Sociology of Mental Illness at Rutgers, and under the gender section, I always include this population, but I look for resources, and maybe I'm asking this of the Denver researcher, where my daughter lives, I might add. Love Denver. Anyway, the resources, if anyone can point out any one particular thing, I don't expect you to give me a list of everything, that would be helpful for young college students that I'm teaching, because I certainly do include this material in my class. And I think it's really important to get that information out of what are some of the mental health concerns. I mean, we can generalize from everything that's been said tonight, and it's very helpful, but does anyone have any one particular reference they think would be good for college students looking at mental health issues? Of course, is the Sociology of Mental Illness. And I would welcome any recommendations or advice. This has been very useful to me, and I would like to take some to my class. I know your research that you were talking about is more about caregiving and elderly and caregiving settings, and that is very important. I'll go back and listen to this recording again. I just wonder if there are any other.
We can send you some. But part of it, and thanks for asking the question, and thanks. I would love to take your class. One of the things though, with the 31 that actually it's publishing, it's out, should be out soon. We address a lot of the issues, and so many of the issues were mental health related. In particular, I actually ended up having, we had several veterans who were discharged with dishonorable discharge and the impact that that's had. So it outlines some, I mean, it'd be more Colorado based, and I know, I feel like Sage has a pretty robust overview and even map too in Boulder that I can put them in the chat right now.
Okay, thank you very much. Thank you. It's been very helpful. Thank to all of you presenters.
With the time remaining, I wanted to circle back to one of the points that was brought up earlier, and that's about data collection, SOGI data collection with this population. And it's been said, you know, we don't count until we're counted, right? And we made a lot of progress under the Obama administration in getting SOGI data questions into a lot of the, you know, the federal surveys and larger studies. And then of course we had to battle to keep them from being taken out for the past several years. But and do any of you want to sort of speak to like the importance of, or you know, what you've seen going on with SOGI data and how we can, you know, the importance of using that data to better serve our population?
Well, if I can join in here for a second. My name's Kevin, and I just retired as a nurse researcher for the last 30 years, a lot of years. And when I started to collect more descriptive SOGI data, I found that my colleagues were uncomfortable with it and didn't quite understand it. What began to make a difference was when I was doing presentations, and I would say that 14 of my respondents identified as transgender, male to female, and that would just blow their mind that there were actually participants who would answer these surveys and say that they were, you know, female to male or male to female, transgender, or non-binary, which of course I had to explain to them all the time what it was. But I found that sometimes just collecting the data and then showing the data actually begins to change people's minds, because somehow I think they have some wild fantasy that collecting these data are going to be somehow bad or dangerous or impossible to gather. And they're certainly not. In fact, participants were more than happy that they were given a lot of choices as to how they might identify. So I think that's one of the things. I think that organizations, I have certainly found, need a lot of help from all of us on how to collect that data, how to do it appropriately. If they only have 5 choices, what might be their 5 choices? If they have 11, all right, great, you've got a lot more opportunity. But how can you best do it? And I don't think there's any one way. I mean, I think if I asked everybody in this call, you'd all have a different response probably. But it's the attempt to do it to be as inclusive as possible. I did want to make a comment on some of the discussion you were having earlier about, you know, what works with changing minds and what doesn't. I would say it all works. I'd say that every approach we take works. I was a professor for the last 20-something years teaching undergrads, grad students, and PhD students. And another thing that we talked about was being a bystander. And what did it mean to stay silent when someone's being called a faggot and you didn't speak up? And for some young people, that was a big step for them. It sort of opened their mind to, oh my God, I have a responsibility here to help, you know, save the respect of other people. And that are being called names and all that. So I think there's so many different ways in which we need to approach this that all of them, I think, are really useful. And it depends what population you've got. And then my final comment is, because I just want to make you laugh. I'm writing my memoir now. I was the first openly gay professional firefighter in the United States. And that was in 1981 to 1985. And as you might imagine, I had 4 years of sheer hell. So I'm writing my memoir. But when my husband and I were listening to the Washington, D.C. fire folks be so upset that they would be the fire and emergency management people, the FEMS, I came up with a great idea that the gay community should really get together and say, we're going to support you in everything you do in the fire department. We're going to be fags for FEMS. I thought, gee, wouldn't that just kick them right off their chairs? Of course, we didn't do it. I'm a lot more serious than that, but I wanted to say I appreciated the input from everybody tonight. It rings true, and the only other thing I'd ask people to think about, because I imagine a lot of you might be involved in things outside our country, is I've spent 15, 16 years working in sub-Saharan Africa and never hid the fact that I was a gay man, and certainly getting older. And found that when you were genuine and really supporting people and respecting them, the people of all different tribes would come up to me and ask how they could take care of their brother, how they could take care of their uncle and their aunt and their children. So to think more than just the United States is, this is a worldwide issue with LGBTQ plus people and aging.
Yeah, thanks, Kevin. And I actually want to go to Sylvia Fisher, an old colleague, is on the phone, not old colleague, a colleague from a long time ago, I should say, who was on the phone and is very much involved in the federal effort on SOGI data collection over in the HRSA and formerly SAMHSA. But Sylvia, can you take just a moment to talk about like SOGI data collection from your point of view?
Yes, thank you for the opportunity to speak. Hi, Dee. Hi, Stephen, and everybody else. Thank you all. Wonderful to see both of you and all of these wonderful distinguished colleagues. I just wanted to give a brief update on what's happening currently on this front, because after a period, as you all know, the long dry spell during the last administration of no significant efforts, although there were subtle and sort of well-hidden efforts among federal agencies to do some data collection around SOGI. Now there is an overt effort to do so, and there is a lot of support. In fact, depending on your point of view and how rigorous a survey methodologist you are, you might think that it may be going a little too fast. There's a considerable amount of pressure on a number of the federal agencies that are doing large-scale federal surveys to produce SOGI questions that can be implemented very quickly. And the challenges are, number one, that there's not, it takes a very long time to do cognitive and field testing in order to assess which questions should be included on federal surveys. And it can take sometimes 3 or 4 years. And now some of the groups that I'm associated with are taking 3 or 4 months. On the number two, there are many identities that are coming to the fore that apply, I think, perhaps more with younger populations than the ones we've been talking about. And that is presenting a challenge in terms of what specifically to include as options on these SOGI questions. Those include right now, one of the front runner terms that's not been used much in federal surveys, if ever. Non-binary is being considered for some of the surveys as additional questions. OMB, the Office of Management and Budgeting, just had a special quick and urgent group, which I was a part of in April, that produced a couple of questions that were included on the Household Pulse survey, which, if you're familiar with, is the survey that is administered by on the phone, by text, in order to get information about how people are responding to COVID and the pandemic. And they wanted to add LGBT, so the Hurry Up group did develop two items on this that were added. However, they are not optimal items, and I'm going to put in something right now about this that you will see. So the items were not great. The question was, let's use items that we tested. We quickly went through it. There's a CNN profile that came out when those were released last month, and actually early this month. It is an opportunity to have, LGBT representation on the Pulse survey, which is being used so much to report a lot of what's happening in terms of how the public is reacting to various aspects of the pandemic. So that was a definite push, but a very, very urgent, critical push in terms of timing. Even right now, and this is not what we know, but there's the Department of Agriculture is looking at their statistical census of farmers to try and include these questions. And they're having some challenges. They've never done this before. So they've consulted other groups that have done a lot of this, like the Census Bureau and the National Center for Health Statistics. So there are some efforts that are underway, even in surveys that have never really done this before, to make this happen. My theory is that they want to make this happen before there's a change in Congress, and maybe there'll be a stop put to some of this effort. So I just wanted to give you all an update to let you know. I do think that there is going to be more focus on, more older age, aging populations. But at the moment, a lot of the youth and the questions around transgender and gender identity are a bit of a challenge. And there's going to be some more work on that done. The sexual orientation question is generally accepted, and that's the one that was developed by the National Center for Health Statistics a few years ago. So thank you for letting me give an update.
Thanks for the update, Sylvia. I really appreciate it. Right from the horse's mouth is always best. We're out of time, but there was
some kind of one end of the horse.
One end of the horse. Oh, be kind to yourself, Sylvia. We're at time, but there was one other question that perhaps someone else can handle here, and I wish Aaron were still on the call, because he could really do this. But from Sophia over at Capitol Hill Village, very good friends of our program, and thanks for coming back on. This has to do with the LEI, the HRC SAGE Long-Term Care Equality Index. And its impact, and any sense of like how that effort has had any impact for this community.
I don't know. I've worked with Beth Higgins in Ohio, who was part of the steering committee for the LEI, and I know it started. I don't know how many people have participated, and I have had a hard time finding actual data on it. So I don't know if it's just too early to tell. I know people are participating in it, but I'm anxious to find out what they're finding.
Yeah, I think it probably may be kind of early. And then, the HEI has had its impact, and the Corporate Equality Index, of course, you can argue has had its own impact too. And HEI sort of is sort of spawned by the CEI. So we hope, and my sense is that the HEI is really, people, hospital systems really want to be thought well of by our community, and that's one of the mechanisms and tools for doing that. So, I think we're really at the very end here. I'll get one more last comment in here from Diego, since he just put this in about State Department committed to pursuing gender X on passports and overseas birth of U.S. citizens, because President has asked for it to be a model for all federal agencies. That's an important comment to make here too. I'm afraid we are at time. Thanks, Diego, for that last bit. This has been fun. I really appreciate and edifying for me, certainly. I want to thank Bob Linscott, Dee Magrini, and Carey Candrian for joining us, and Aaron at the very beginning for joining us. Great conversation. I hope we can keep this going. I know with our program, we will be revisiting aging of our population in the future too, and be ready for a phone call from me asking you to come talk to our students at a future residency directly. But my thanks to all of you for joining, and thank you for coming. And those of you, if you still would like to make a donation to our humble little program and our our little our scholarship fund, I'll just put that in there one last time in the chat, just in case everyone wants to have that chance to do it. There you go. And thank you for coming this evening. Anyone who was on the email distribution list and registered for this, once the recording of this is available, we will send an email with the link so you can go back and watch it. So thanks everyone for coming. Great conversation, and I appreciate the input from everybody. So thank you so much. Good night.
Hi, Steve. Hi, Dee. Thank you all so much.
Hi, Tam. Good to see you.
Right.
Thanks.
everybody.
Yeah, see you
Awesome.
Friday. Hi, Tiffany. Hi, everyone. See you later.
Dr. Moss, so nice to see you.
Always,
All
always.
of you.
Bye, Dee. Thank you so much.
Bye.
I know, I don't want to leave now. See
You're
you
just
later.
watching people leave. That's it. Bye-bye.
Yeah, y'all keep safe. Take care.
Bye, Max. Thanks for the great question.